My name is Dr. Nirav Pandya. I'm the Chief of Pediatric Orthopedic Surgery here at UCSF, and I'll be talking about pediatric pelvic and acetabular fractures. I have no conflicts of interest to disclose. So the goals of this talk will be threefold. Number one, we'll talk about the epidemiology of these injuries. Number two, which I think is really important for the general orthopedic surgeon, is understanding the differences between pediatric and adult trauma in terms of the pelvic and acetabulum, as well as talk about some management pearls. Well, the first important thing to understand that children are not as small adults. Now, I understand that we hear this a lot in terms of pediatric fractures, but I think particularly around the pelvic and acetabulum, that's important as well too, because we do have a tendency to think because we don't really necessarily associate growth plates and growth disturbances with these injuries, even though they do exist. We do have to use different treatment principles and understand how these injuries present differently when taking care of them. So the question is, why should we care? This is a quite relatively rare injury that we see in this population, but it is something that if it does come to your trauma center, it's appropriate to be able to identify, understand the differences in terms of care, and what are some of the issues in terms of morbidity and mortality. Now, the important thing to understand, we're seeing more multiply injured, critically ill children. And that the reason for that, even especially now post-COVID, is that we're seeing increased participation in high velocity activities, and we're seeing more adult type trauma in younger and younger patients. Now, there are some physiologic differences when we see these patients coming into our trauma bay. The first important thing to understand when you look at it from a morbidity and mortality standpoint, this is generally due to the pelvic fracture in adults. It's due to the solid organ injury in children, so not necessarily the pelvic fracture itself, which is causing bleeding, which is leading to death. And there's a higher risk rate from neurologic injury in children than adults. So when these patients come in, they have severe multi-system trauma, whereas adults may not necessarily make it in terms of lifespan expectancy or actually living through the injury. Children who may have a very severe neurologic injury do have a tendency to survive, even though it may look very grim early on. Now let's talk about the pelvic fractures, particularly concentrating on the ring first, and then we'll go on to the acetabulum. If you look at pelvic fractures as a whole, they make about 1% to 2% of pediatric trauma. Most of these are automobile injuries, and the key thing is that there are a lot of associated injuries, and those are the ones you need to be concentrating on. The difference in terms of the anatomy is that in general, you'll get a single break in the ring in pediatric patients. We just don't see that in adult patients. One of the things we always know as residents is look for the other break, but you can get a single break in the ring in pediatric patients. You get more SI, symphysis elasticity. So whereas there would be a break in an adult patient, in a pediatric patient, we get stretching without that actual break, and there's decreased mortality. There's also decreased hemorrhage as well too. So that's where that decreased mortality comes from. Whereas an adult patient may have a significant amount of hemorrhage and may die from that pelvic injury. In kids, you just don't see that same amount of vascular insult. In addition, you get LC grid and AP patterns. Typically, kids are passengers and they have decreased pelvic volume and less bleeding overall. Now, if you look at the study that was done in the Journal of Trauma several years ago, where they looked at pelvic fractures in pediatric and adult trauma patients, are they different injuries? This was a retrospective study of all trauma admissions at USC over an 8-year period. They found that the pelvic fracture incidence was about 10% in adults and 4.6% in pediatric patients. The injuries that cause the pelvic fractures were usually car accidents and pedestrian injuries, which are 2 times more common in adults, and falls from heights were 7 times more common in adults. The solid organ injury rate was the same in both groups, it's about 11.5%. The death related to bleeding caused 42 deaths, about around 3% in adults, but there are no deaths in pediatric patients, just something important to consider when you're looking at these injuries. Now, there are a couple of studies that are out there that look at these injuries kind of more globally. This was a study that was done at Children's Hospital of Philadelphia that looked at 166 pelvic fractures in pediatric patients. They found that patients who were immature typically had pubic rami and iliac wing isolated injuries. Immature patients usually had more associated injuries that drive treatment, whereas the skeletal mature population had more acetabular fractures, SI injuries, or anterior diastasis. And it really was the pelvic fracture that drew morbidity and mortality in these patients as opposed to the associated injury. Now, when you're thinking about how we classify these injuries, you really want to look at the triradiate. Now, basically breaking it down whether the triradiate is closed or open. If the triradiate is closed, the iliac wing is stronger than the pelvic ligaments, and you get adult type injuries and you get disruption of the ring. The triradiate is open, the iliac wing is weaker, and the iliac wing breaks, and there's not necessarily that disruption of the ring that you see in adult patients. There are multiple different classification systems kind of in the closed triradiate kind of group of patients. You can use the Young-Burgess classification, which is used just in adult patients. In pediatric patients, you got the Turod-Zia classification because the triradiate's open. And when you look at this classification system, you break it down in different numerical groupings. Group 1 is an avulsion. This is what you see more in your athletes, where you get a sartorial avulsion from the ASIS or a rectus avulsion from the AIIS. Group 2 injuries are iliac wing injuries, where you get a direct blow to the iliac wing. Group 3 injuries are simple ring injuries. You have pubic rami and pubic symphysis fractures. And then complete ring disruption injuries are your bilateral rami fractures, straddle injuries, SI joint disruptions. And in terms of treatment of these injuries, typically, if you can treat these conservative in general, if there's hemodynamic stability, these are generally weight bearing tolerant injuries, your type 1 and type 2 injuries. If you're hemodynamically stable when you're looking at your kind of type 3 injuries, that's typically when the posterior ring is tracked. They can be weight bearing as tolerated. And really, it's only really rowdy children where you need to kind of limit their transfers just so you don't have delayed healing or increased pain. And really, it's your type 4 injuries. Those are the ones where there typically is hemodynamic instability, and that would be more operative. These are your type 4 injuries, and these are the ones that need open reduction and internal fixation. Now, besides hemodynamic instability, when do you operate, right? That's really the question. I think if someone's hemodynamically unstable, they have a type 4 injury, it's very clear. Type 1, 2, and 3 injuries typically aren't going to have be hemodynamically unstable. So those are ones that can be treated non-operatively. But there is definitely a gray zone. Is there too much displacement? Is there a certain pattern that will cause you to operate? I think the key number for everyone to remember is 2 centimeters. So if you have more than 2 centimeters of posterior displacement, you'll get poor outcomes. And this was a study that looked at 18 patients who are pediatric. We found that if you had more than 2 centimeters of posterior displacement, you had poor SI joint remodeling because the anterior ring remodels, but the SI joint wouldn't remodel. You can get leg length discrepancies and you can get neurologic deficits and as well as low back pain. So if we look at kind of long-term outcomes of SI disruptions in children, you want to do posterior SI screws and reestablish the anterior ring by plating if necessary. Don't do what they show in that in that image right now, where you've got wires and kind of these constructs which don't take into account the tremendous amount of force, even in a pediatric patient, that is across the pelvic ring. Now we're going to jump to acetabular fractures, and the epidemiology of these injuries, they're extremely uncommon. The vast majority of them are non-operative. If you have a closed triradiate, you use adult principles. But if you have an open triradiate and acetabular fracture, there are some special considerations. Now, first important thing to understand is that if you do have a fracture through the triradiate, you can get leg length discrepancy, you can get growth rest, and you can get acetabular dysplasia. And if you look at the rate of triradiate injury, it does vary across the literature. It can be 0.8% up to 15% based on what study you look at. There are various different studies that have looked at this in the literature historically. And basically, what's happening when you get an injury to the acetabular triradiate physeal cartilage, you basically get the injury, the medial wall thickens, you get a shallow acetabulum, and you get femoral subluxation. Okay. And typically, we look at age as the most significant risk factor in the development of post traumatic acetabular dysplasia. Children younger than 10 years of age are at the time of injury are at the greatest risk. Now, obviously, that group of patients are very rare for them to get an acetabular fracture. Because that triradiate is still open, there's so much more growth potential. It's a very, very young age group. Even though we think they're going to heal everything, you have to worry about these acetabular injuries. So when you classify acetabular injuries, you divide them into shear type injuries or compression type injuries, right? And these are kind of two examples of what can happen when you've got a shear injury versus a compression type injury. The good news is that the majority of these, even though there is a risk of growth disturbance, are treated non-operatively. You typically do bed rest, you can do traction, you can do spica cast, you can protectively immobilize them in some sort of fashion. The question is when to operate. So really the indications are if you get more than 2 millimeters of joint displacement, because even though these fractures will heal, the articular incongruity can be something to be problematic for children. If you have joint incongruity, even if there is kind of less than 2 millimeters displacement, if you have incongruous joint, you want to operate on them. And if there's joint instability, particularly near fractures and dislocations. So if you look at treatment for these injuries, this is an example of a kind of an acetabular fracture needs fixation. You have hardware placed in, you can kind of see how the pediatric patient, once that kind of anatomy is restored, they heal very well. You can see how they're doing 3 months post-op. But it's important to note that even if you get a great reduction, as with all pediatric fractures, even though operative intervention can help to stabilize a fracture, the initial injury insults what causes the growth disturbance. So even though you do great surgical fixation, growth disturbance can still occur even after operative intervention. I think it's important to understand that. So if you do have a growth disturbance and you kind of then have that happen, what are the options? Well, you can do early reconstruction in terms of a physeal bar excision. So then basically you can allow that acetabulum to basically remodel. And you have late reconstruction in terms of pelvic osteotomy. So the same sort of principles that we have in other areas around the body in terms of excising the physis and allowing it to grow, or then doing osteotomies later to deal with growth disturbances as well too, but you are worrying about this kind of acetabular dysmorphology, which can occur due to this triradiate injury. So, in summary, in terms of pelvic fractures, it's a rare entity that we see in pediatric patients, but the majority are treated non-operatively. A pelvic fracture will not lead to morbidity in a child, excuse me, mortality in a child, but it's the associated injuries that will. So, even though the pelvic fracture is there, it's important to get general surgery, get all the various services involved, because even though the concentration will be on the pelvic fractures, these associated injuries that you're worried more about. The remodeling potential is quite poor if they go beyond a certain degree of displacement and congruity. 2 centimeters is key, particularly for posterior displacement. And it's important to recognize that triradiate injury can lead to growth disturbance. Thank you very much.